I am doing my first rotation at Holton Community Hospital. It is a pretty small hospital. I think there's about 10 beds total on the floor, so it's very small. So we get to see inpatients, we get to see some outpatients, and even some home health. So it's been really cool. I've been able to see tons of different diagnoses in all three settings, which has been awesome. So in thinking for ideas for this project, I was trying to think of something that would be helpful for everybody in the therapy department, not just OTs, but PT and speech as well. So in thinking about this, I tried to find a common denominator in all the patients that we are seeing. And one thing that I noticed first off the bat was the fact that it was mostly geriatric. I would say about 80 to 90% of the patients are over 65. So that's definitely a common denominator for the patients that all the therapy team sees, whether that's inpatient, outpatient, or home health. Outpatient, there is a little bit more of the younger generation, but for the other two, it's largely, for home health and inpatient, it's largely geriatric population. So with that, there is a lot of dementia, whether it's diagnosed or not. There is dementia and Alzheimer's and just overall cognitive decline with a lot of these older patients. And so I thought of my project just based off of that and the prevalence of that. And so basically, my project was I researched dementia, cognitive decline, and then I researched further into strategies to working with people with this diagnoses, and really coming up with lots of strategies to help therapy sessions be more productive to both the patient and the therapist, and less frustrating for everyone, and just more successful overall. Because I thought this would just really be an area that could benefit, like I said, all the therapists involved. And especially for PT, I was talking to an OT about this, and she thought it was a good idea, particularly so because PTs in school, they don't get the kind of cognitive background and education that we do as OT practitioners. So a lot of them might not even have ever had to learn the pathophysiology of dementia and Alzheimer's and how exactly it affects the cognitive processes of people who have it. And so to kind of give them that medical, scientific background to really understand what's going on with these patients and why they're not understanding what they're being told to do, or why they're processing it the way they are, or the actions that they're taking. So I actually haven't given my presentation yet. I'm supposed to take it on Monday morning, or give it Monday at noon. That was what was best for the therapy department, so that's why I'm giving it. So I haven't actually gave it yet, but I'm hoping that I will get positive feedback for it and it will be helpful. So I will just run quick through a couple of the things that I will touch on in my presentation. So I kind of just gave a quick overview of dementia, that it's the result of damage to nerve cells within the brain, and the different kinds of dementia and the prevalence: Alzheimer's, vascular dementia, mixed dementia, dementia with Lewy bodies, so on and so forth. And then I got into the diagnosis of dementia. It is required to have at least impairments of at least two of the following: visual, perceptual skills, reasoning and judgment, ability to focus and pay attention, communication, and language and memory. So just gave a little general synopsis about the diagnosis and what is needed to be present in someone to get a diagnosis. And then I kind of went through the cognitive processes that are involved: implicit processing, explicit explicit and metacognition and what those are and how they are affected by dementia. And then I will talk about the different types of memory: sensory memory, short-term, and long-term, which is divided. Long-term is divided into explicit, and then declarative, and then episodic and semantic memory. And long-term is also divided into implicit and procedural. So just a little background on the different types of memory that are impaired. So once we have a background and understand how the memory is affected by dementia, then we can really understand what's going on behind the patterns that they're displaying, or the communication that they're showing, or the questions that they're asking, actions they're taking, just so we get a better sense of the whole person and what they're really going through. So then I talked about approaches to exercise should include goal setting, self-monitoring, provision of feedback, problem solving, reinforcement, and then chaining. Those are all concepts that should be used when trying to come up with therapy for these patients, whether that be just more TheraX based for PT with gait training and transfers and lower extremity, or with OT, upper extremity, and also our ADLs and TheraX generally would be the main things that we'd work on with these patients. I talked about some common barriers that might be experienced in therapy due to this condition, which could be difficulty following directions. And to combat that, you could use strategies such as just keeping it simple, use multiple modes of cueing, learning by modeling, and external memory aids. Another barrier could be conversational. So with that, you need to have patience and acceptance, rephrase questions, and narrow their choices down. Another one could be connecting with others. And so with that, you can use external memory aids, such as like picture books to remember names, and family and staff training, so everyone's on board and understanding the techniques that therapy is using. And then from there, I just challenged therapists to think deeper, as I kind of mentioned before. When you're faced with signs of dementia that may seem misguided, or like there's not really any purpose to the actions they're displaying or the things that they're saying, that they're really random and they're just they're not connected to anything really. You just sometimes need to ask yourself why they're actually behaving that way and what they're really trying to achieve, even if it's not what it looks like. Just off the bat. So a couple examples of that would be, are repetitive questions being asked because the client is actually seeking the answer to that specific question, or are they just seeking attention? Are they lonely? Are they depressed? What's going on inside their brain that's causing them to ask these questions? Another example is the client wandering because they don't know where their room is, or because they're seeking social contact or attention. So, I mean, that's kind of hard to decipher sometimes, because a lot of times dementia will affect their orientation and their short-term memory, so they don't know where they are. But sometimes it's just easy to write it off as that being what it is, when it could be something a little more psychological, such as craving that social contact. So, and then I encourage them to focus on the patient's strengths. And when we see patients with dementia, they are still to the point where they can still, a lot of them still function in their homes, or if they're not, they maybe just had a fall or a hip or knee surgery or something that landed them in the hospital, and they might not go back to their homes, or maybe not right away. They might go to a skilled nursing facility or a nursing home, and they might not end back home. But a lot of times you will still see that their ability to stay focused for at least a certain amount of time is still there. Their memory, especially their long-term, is still intact somewhat. Their reading and aspects of language, right-left orientation, and emotional memory are all strengths that these clients should still display, and you can work off of those when developing therapies. compensation, such as short-term memory, like remembering where the room is, what the next repetition of their motion is, like if they're doing elbow extension and flexion or whatever you're working on with them. If you're just starting that with them, they're probably not going to remember every single repetition right away. Problem solving difficulty is another area that they're going to have difficulties with, such as getting dressed or managing their walker or wheelchair. One of the biggest ones we see is, I'm sure some of you guys have experienced this, but transfers. In almost every single one of my notes, I feel like I'm marking the fact that they needed a verbal or tactile cue to lock their brakes before they sit down. And again, that one's kind of tricky because sometimes you're asking yourself, okay, is it really because of their dementia or cognitive decline that they're forgetting to do this, or is this just the way that they always operate and they just, maybe aren't thinking of the safety of it, or they've never had a fall because they haven't locked their brakes, so it's just not something that they're used to doing because they don't think they need to. But that is a problem-solving step that can be complicated by dementia. Orientation is another area that they could be lacking. Obviously, that one's pretty self-explanatory. And then perspective memory, which is things like remembering to tie your shoes or put the lid on the toothpaste or turn the stove off, and so on. So then I gave I'm going to, when I give my presentation on Monday, I'm going to hand out some handouts for different strategies to help with the process of having therapy sessions with patients with dementia. So the first one is just a basic hierarchy of cueing and prompting. So I will flip the screen maybe and show you guys what this is. So that's what I will be handing out. So that will just, I don't think I can get my screen to flip. I'll just read some of the points. So cueing is an action intended to encourage a student to initiate or continue a task he or she has previously performed. And this handout is actually aimed towards students, so it is more educational verbiage being used, but obviously you can replace it with patient or client. So first is give a verbal or indirect cue, and then give some examples, and then a verbal direct cue, then a visual cue, then pointing, and then a physical gesture. So that's how cueing works. And then prompting is an action taken to directly assist a client with the completion of a task. So this time we start with just a verbal direction, then a gesture assist, a visual graphic, student modeling or client modeling where they demonstrate, and then a physical assist such as hand over hand. So that is one of the handouts I will be giving. And then the second one is on spaced retrieval, which is another really effective method that I've found in my research, especially with clients with dementia. And so it uses procedural memory to help people recall information over progressively longer intervals of time. So this is another really good one to use with transfers, whether they're forgetting to lock their brakes or they're forgetting to line their walker up right up to their chair, or they're forgetting to either push off of their chair and then grab their walker, or vice versa, reach back for the arms of their chair before sitting down. Because those are things that in my population I've noticed are very common and things that you find yourself repeating a lot just to ensure the safety of their transfers. So with space retrieval, just a quick rundown of the steps. So you choose one or more functional targets or goals. Then you ask a question to elicit the target response. If the person answers correctly the first time, choose another target for the session. If the answer is unknown or incorrect, tell or show them the right answer and have them repeat it back. Ask again 15 seconds later. If they can't recall, give the answer and have them repeat it back. Try again in another 15 seconds. If it's still not right, space retrieval may not be appropriate. Fourth step, when the answer is given correctly, double the time interval. So go from 15 seconds to 30 seconds, then 1 minute, then 2 minutes, 4 minutes, 6 minutes, or I'm sorry, 8 minutes. So that's a really important step. That's the only part that's super objective about this method is the amount of time, which can be kind of hard when you're in the middle of a therapy session and you're trying to help them don their pants and you're not really looking at your watch, you know, to see exactly how much time has passed. But if you can, I guess that's just the most effective way to do it is at those specific time increments. So that's spaced retrieval, and it's been proven pretty effective, and I have been able to try it a couple times with some of my patients, especially with the break and transfer training thing, and it seems like it has been effective, and they have been able to recall the steps that they're supposed to do when I've been posing them in this way. So that one's pretty effective. So they will be receiving this handout on that. That'll be part of the package that they're getting. And then I think I just have one more. And then this is, errorless learning is the last big method that I found really effective for helping patients with dementia. So with errorless learning, I'm pretty sure we talked about it in class too. It's pretty self-explanatory. It's just basically you don't acknowledge any mistakes or errors that the patient makes. And so like in this infograph, you give the instruction, you give one prompt, such as hand over hand, or doesn't matter what it is, if it's tactile or verbal, a prompt to do the task that you want them to do. And then if they give the correct response, then you immediately reinforce with positive verbal encouragement. That's great, good job, you remembered, perfect, whatever you want to use. And then, so then the next hierarchy down would be you give the instruction, you give prompt 2, such as partial physical or partial verbal, so a little less of a prompt, less verbal cues, less tactile cues. And then if they give the correct response, again, give the immediate reinforcer. Keep on going down to giving another instruction, give your prompt number 3, such as just gesturing. So instead of actually verbally telling them what to do or touching them and helping them figure it out, you can just kind of vaguely gesture towards, like, okay, here's your walker. What do we need to do? Then if they give the correct response, immediately reinforce. And then the last hierarchy, don't even give a prompt, and hopefully they will do it correctly. And if they do, then you immediately reinforce. And so that's just the third method that I have found in my research to be super effective with patients with dementia. And that's pretty much my entire presentation. And this video is pretty long. I apologize. Didn't mean to make it that long, but I wanted to hit the highlights. So I hope you guys maybe learned something that will help you if you ever get to work with the geriatric population. If they do have dementia, hopefully some of these strategies can be helpful. And I can post the handout links if anybody wants them. I think they'll be pretty effective. Hopefully the therapists at my hospital will think so too. So thanks guys. Hope you're having a good week.